Hello, good afternoon, dear colleagues from sunny Basel. My name is Johannes Bitzer. I'm an obstetrician gynecologist, former chairman of the Department of Obstetrics and Gynecology, and I'm also a lecturer in psychosocial and psychosomatic medicine and the director of the Diploma of Advanced Study in Sexual Medicine. So I've tried during my career to combine gynecology also with psychology. So this is the approach actually I'm trying to take today to look at the issue of androgen excess in women from a medical and also from a psychological point of view. Look at this young lady with 17 years old. You can see that she has acne. There is hirsutism. She reports oligoamenorrhea. Here you have the classical laboratory values. You have sonography with 10 small follicles in the periphery of the right ovary. You have an AMH of 4, and you have in the lab the increased values of androgens. So when we look at it from a more comprehensive point of view, I think we should always in medicine try to look at the disease, but also at the same time at the person and the natural and social environment. This is especially important when it comes to chronic conditions like androgen excess, where you do have a complex biopsychosocial disorder. Now, when we look at it, what does it mean actually when we try to combine these different aspects? We have on one hand the disease, where you have heard now several webinars about diagnosis, standardized diagnosis, about treatment guidelines. And when we look at the person, we would have to look at psychological factors contributing to the disease. We would have to look at the quality of life and how does the person cope with the chronic disease. And certainly when it comes to the more social cultural background and the environment, it's about work, it's about relationship, it's about family, it's about social norms, which have a context to the disease. So regarding the disease, as I mentioned before, you have already heard in several seminars about androgen excess, about the different manifestations, acne, hirsutism, SARA syndrome, PCO syndrome. You have heard the general medical approach, which is the description of hyperandrogenic symptoms, gyne history, general history, gyne exam, ultrasound, endolab, early personal history, and family history. We have gone through this in several seminars. You have also heard that from a medical point of view, it is a real syndrome. It's a complex combination of possible different symptoms, where you have a combination of any hyperandrogenic skin symptom with or without menstrual irregularities, with or without infertility. So these are the main disease subjects. And to handle this part, I think it is just important again to remind you we have to understand about androgens in women. We have to understand that the adrenals are responsible for 25% of testosterone, 50% of androstenedione, 70 to 80% of DHEA, and 90% of DHEAS. The ovaries provides 25% of testosterone, 50% of androstenedione, and 20% of DHEA. And that both systems, both organs are regulated, of course, by the pituitary, by FSH, LH, and ACTH, which are all involved together. But what makes the issue even more complicated and multidisciplinary, that is the fact that the human skin plays an important role in the development of peripheral hyperandrogenic symptoms. Up to 50% of circulating testosterone is produced in the skin and other peripheral organs. What is also important is that testosterone itself is not the end active organ. It's dihydrotestosterone, which is synthesized from testosterone by 5-alpha reductase in the skin, which is an important player also in the game. You have also heard, and this is again basically important when it comes to the disease treatment, that you have these issue where when you have a patient with severity of acne, cycle, and hirsutism, if the symptoms are mild, there is not a necessity for hormone analysis. You would do SHBG and prolactin. But if you have irregular cycles, then you have to do a differential diagnosis, which really differentiates androgenital syndrome, adrenal hyperplasia, adrenal tumor, ovarian tumor, and PCOS as the main important clinical conditions finally. And you can do that by making an analysis of the different androgens. This again was represented in previous seminars, and I would really just like to stress the point that 17-hydroxyprogesterone is a very important leader in the diagnosis, and the amount of free testosterone is also very important to realize. Finally, we also stress the point that when you have one androgen sign, look for more. In dermatology, acne, oily skin, alopecia, hirsutism, seborrhea. Regarding internal medicine, look for android, obesity, hypertension, insulin-resistant, lipid abnormality, adrenal hyperplasia. And in gynecology, menstrual irregularity, infertility, fibrocystic breasts, endometrial hyperplasia, ovarian enlargement, PCOS. So a large spectrum. Now, when it comes to the person, what are the issues which we should assess then? I think from psychosomatic medicine and from psychology, we know that you should assess the subjective experience of symptoms, not only the objective ones, the symptoms of quality of life, the coping style, and the behavioral consequences. Finally, this all comes together in what we call psychosexual health, mental health, and interpersonal health, which are important contributors to global health. Let me briefly revise a little bit the components of psychosexual health. What do we mean by it? It's the body image, which is actually the inner representation, the model we have of our body, and its outer appearance. What do we think about our body ourselves? The sexual identity, of course, is again the inner representation of the gender and stability and continuity of sexual preferences. It's very close to our general identity. Then the issue of sexual health is really being able to enjoy sexuality, feeling desired and wanted, realization of sexual wishes and fantasies, and to be able to establish a satisfying relationship, being assertive and self-confident in establishing and maintaining contact. And all this, of course, contributes to emotional well-being. Now, the stress of hyperandrogenism or hyperandrogenic symptoms to psychosexual health is on several levels. You have, for example, the issue of skin and hair fat distribution, which can contribute negatively to your body image. The male pattern, which may question somehow sexual identity. The increased self-awareness and control, which this insecurity, which make it difficult to enjoy sexuality. Maybe also some of the patients avoid contact to establish a sex, which makes it difficult to establish a satisfying relationship, not feeling attractive and desired, which all contributes to the diminution of emotional well-being on the subjective side. Very briefly, some studies have shown how the mechanism is. For example, there are even long-term consequences. If you are dissatisfied with your body, if you reject your body, you may neglect it, you may have disturbed relationship. And on a long term, this may lead to misinterpretation of bodily signals. And we can see that some of these patients develop somatization disorders, for example, with chronic unexplained pain, and of course, contact difficulty. Now, the issue of gender identity is very important. It's about insecurity and social rejection, which may lead to depressed mood. And again, some of these patients, you may have noticed that over the years they are withdrawn, they are anxious, they may be also aggressive and demanding, and this, of course, may also lead to relationship difficulties and what we call then the difficult patient in our consultation. So this is a little bit the overview where we have to look into possibly long-term negative consequences of androgen excess in women regarding these different aspects of psychosexual health, which very often finally leads to something which is important for mental health, and this is the loss of self-confidence. So how do we assess this? I think we should really be able to make an open interview. Doctor, I'm quite worried about my oily skin and pimples. My girlfriends were addressing this, and my weight. That you would really look into different complaints and try to evaluate them. How important are they? Many of these patients have different complaints: seborrhea, weight. Quite frequently they have dysmenorrhea, they have cycle irregularity, PMS. They want to be taken seriously with their symptoms. And a simple instrument is really that you try to scale it, that you would ask questions with scale. How would you rate your satisfaction with your sexual life? How would you rate your general well-being and your vitality? How would you rate your satisfaction with your body? You know, that helps patients who are usually quite ashamed about different aspects to talk about it. For example, you can say you rated your satisfaction with your body 3 to 4. Am I right to assume that there is some dissatisfaction? Where does it come from? Well, I do not like to talk about it, but I find that I'm not attractive, my skin and this hair growth, etc. Or you comment on the satisfaction score of sexuality. Does that mean that you are satisfied and dissatisfied to some degree? Do you want to tell me more about it? It is not that I'm not satisfied. My partner is very gentle and empathic, but I'm always wondering if he's not disturbed by the hair growth around my nipples when he caresses my breasts. You know, this opens a very trustful relationship with your patient. So finally, the aspect of the natural and social environment, I think you should, of course, take a social history, look at the cultural values and possible difficulties also at work, the social stigmata and the integration. I mean, for good mental health, we need good relationships. And the fear of isolation is quite important, especially in these young ladies. So now I come to the issue of management. And here again, I think we should take the 3 dimensions into consideration. Of course, we have the disease. And as I mentioned before, many previous seminars already summarized a lot of the medical treatment and which is evidence-based and standardized. I would just like briefly to summarize again what we have heard, and I think what is also important to provide a comprehensive care. We have the guidelines for acne vulgaris, and it is quite clear that combined oral contraceptives are effective and recommended in women with acne who also desire contraception, or in case of menorrhagia. COC use may have additional benefits. It is important that we can use COC in combination with other systemic drugs for acne treatment, including antibiotics and tetracycline class and spironolactone. In clinical studies, significant improvement of acne lesions during COC use was demonstrated at the end of the 3rd cycle of treatment. This is important when we talk about compliance. Nevertheless, therapy of persistent disease must be long-term because it's actually, as you have heard in one of the previous seminars, a long-term chronic disease. Very often, it may be necessary to have a combined treatment: topical retinoids, antibiotics, benzoyl peroxide, azelaic acid, spironolactone can be used for acne treatment. However, due to the increasing resistance of bacteria to antibiotics, topical antibiotics is not recommended as monotherapy. And as you all know, but some of the colleagues forget it, also some of the dermatologists forget it, that systemic isotretinoin is approved for the treatment of severe persistent acne. However, due to the teratogenic effect, it can be used in women only with reliable contraception. When it comes to combined oral or combined hormonal contraceptives, we have heard about the different anti-androgenic progestins which are available. Here again, you have this classification according to the anti-androgenic effect, which is based on the different levels of action. We have heard that GPA inhibits the activity of 5-alpha reductase. It inhibits the androgen synthesis in the skin and decreases androgen blood concentration through an antigonadotropic effect. We have heard clomidinone has a similar mechanism, Dienogest. The basis is more on a progestogetional effect and a moderate anti-androgenic and anti-androgonadotropic effects. And dosperenone, which blocks ovarian steroid production and also has a blockage or inhibition of the peripheral androgen receptors in the skin. So the three levels of interaction are active in these different drugs to a different degree. Now, regarding hirsutism, again, we have a consensus statement. Low-dose anti-androgenic all-neutral COC, first line of hirsutism treatment. Monotherapy of mild hirsutism is adjuvant for other anti-androgens. Menstrual cycle control in women with hirsutism on PCOS. And we have also learned that anti-androgens can be combined with COC, meaning that you can add an anti-androgen like Androcur to a COC in women presenting with moderate or severe hirsutism, or in those with a milder hirsutism who do not reach a satisfactory control of hair growth using COC alone after 1 year of treatment. They are actually the treatment of choice for hirsutism, and anti-androgens like spironolactone can be used for treatment of moderate to severe hirsutism. But again, taking into account teratogenic effects, it is very important that we combine it with contraceptive. This is just again a little bit a summary of what is available as therapy for patients with hirsutism. As you can see here, anti-androgens, CPA, finasteride, frutamide. I don't want to go into the problems of the finasteride syndrome, but we have to know about it. We have also the creams, the cosmetic therapy, and the laser therapy. Finally, the issue of PCOS, where you also have heard a seminar about it. Hormonal contraceptives, first-line therapy for treatment of menstrual disorders, and acne hirsutism in PCOS patients that allow to resolve these two problems simultaneously. Of course, in those women who do not want to get pregnant. And again, COC is the base of the first-line therapy of all dermatological symptoms of androgen excess in PCOS patients. And the recommendation to use progestins with the lowest androgenic effect. So this was just a brief recapitulation of what you have already heard and what are the medical tools that you have in your hands to help these patients. When it comes to the person who suffers from one of these diseases, I think as these are chronic diseases, it is really important to have a supportive doctor-patient relationship, to be able to communicate and counsel, and also assist in behavioral change and emotional relief. Now, what does that mean? Good listening is an art, and it is summarized in what we learn about patient-centered communication, which is mainly based on responding to emotions and mirroring and summarizing what the patient has said to give feedback. It's about psychoeducation and empowerment. If these young, especially young women, understand better what is going on, they are empowered, they know much more about their body and about what is going on in the body and even what is going on in the brain. When it comes to behavioral change, and this is of course an important issue regarding overweight in these patients, I think doctors should have some basic ideas about motivational interviewing regarding eating behavior and exercise and treatment compliance. Motivational interviewing, which is based on two issues that you try to assess how important is the change for the person in the moment and how confident does she feel in being able to change behavior. And then to identify stresses and teach coping with stresses, assess resources and strength. Regarding the sexual life of a patient, of course, it's again the same elements which need some time, but not so much time. I think in 15 to 20-minute consultation, you can do very good counseling, but you should proactively ask about sexual life. Are you sexually active? Are there any problems or complaints like lack of desire, arousal difficulties, pain during intercourse? Do you have a partner? Is your partner male, female? I think we frequently underestimate the issue of same-sex couples. Then that you would do some basic sexual counseling, which is again about empowerment. Very many, especially young women, are not aware really of what is going on during the sexual response, the human sexual response. They are very grateful if you explain to them about the sexual organs, about the physiology of sexuality, what happens during arousal, what happens during orgasm. A lot of questions about orgasm may come up. And then maybe even invite the partner, if the patient wants, to discuss whether there are any problems and difficulties, maybe also in the partner, and even maybe this is an occasion where the two individuals can talk about different needs and about conflicts. Finally, I do think that women with androgen excess, the whole theme needs some advocacy for patient groups, and also encourage patients to form self-help groups. We do have sometimes questions from patients. In Switzerland, we do not have really effective self-help groups. I don't know how it is in your countries, but I think it is very often with these chronic conditions helpful, especially also for PCO patients, to have a self-help group. It's also about women's rights regarding the accessibility of treatment, to make understand also in our public communication. One is awareness, creating awareness, which we try to do in the AWARE group, as you have heard from Professor Kuba, but that we really make it clear body image is not just cosmetics. I sometimes hear these comments, especially in the critical discussion about hormonal contraceptives, that doctors risk VTE just for cosmetic reasons. I mean, this is a real misunderstanding and a misconception about what we are trying to do, and that many of these issues are not a sort of superficial cosmetics, but it's about health. So cosmetics is not enough. And that we also should take some advocacy that psychological care should be paid by insurance. If we summarize the therapeutic concept, I think regarding the disease, androgen excess as a disease, we have these three pillars. We have to treat hyperandrogenic skin symptoms and menstrual irregularities, to prevent long-term metabolic and neoplastic risks, to maintain and enhance fertility. And as you have heard in the sessions until now already, we do this mainly by combined hormone contraceptives, anti-androgenic progestins, where we have to balance the VTE risk with the effectiveness of the treatment. Very often we add metformin. There are other issues which you have talked about, folate, etc. And of course, regarding PCO and infertility, which is a subject of its own. And regarding the person, I think my main messages to you is that these patients lead long-term therapeutic relationship. They need good communication and counseling skills. They need help, coaching in lifestyle modification, weight reduction, and exercise. And they need also our help to maintain or improve sexual health. And all this together would help to improve compliance with a long-term treatment and in coping with a chronic condition and chronic disease. So combine medical and psychological treatment for the sake of these patients. Thank you very much for your attention.
Thank you very much, Professor. And I see that we have some questions. So the first question is asked by Jean Arnold, and it is: in PCOS and COS are excellent, but what about women whom estrogen SEO-SC are contraindicated? Example, due to high body mass index or focal migraine. What can we use instead? Would it be okay to use spironolactone and cyproterone together to maximize androgenic effect?
Yeah, I think this is one of the challenging questions, but I think we could really, in our practice, very often we first use spironolactone, try to find whether this is effective in these patients. In very severe chronic diseases, we may even think about combining transdermal estrogen with an anti-androgenic progestogen with cyproterone acetate in an individualized treatment. This is what I'm doing sometimes in these patients who are like 40 years old and overweight, you know, where you are very reluctant to give any combined hormonal contraceptive. So in these cases, you have to build a individualized treatment, which may include, in my view, but this is not a evidence-based treatment, or it's not in the guidelines, a transdermal estrogen in the low dosage regarding cycle control.
Yes, and the second question is by Achilles Cruz, and the question is the type and dose of estrogen determinant in the treatment of excess androgen in the woman?
Well, certainly ethinylestradiol has an important contribution in the endocrine treatment, as you all know, by increasing the SHBG and thus decreasing free testosterone. And there are some experts believing that actually this is the main effect of combined hormone contraceptives, and that the role of the androgen, of the progestogen in the treatment is much less important. Unfortunately, we do not have very well designed comparative studies looking into same dosage ethinylestradiol pills with different progestins, especially, of course, LNG, compared to these other preparations where you have an anti-androgenic progestin. So it is true that also a combined hormone contraceptive containing LNG can improve acne. But it is also true that it can induce acne. And unfortunately, as I mentioned before, there are not very well designed comparative studies. It is more clinical experience that I think many of us have made the experience that if we start with the LNG combined hormone contraceptive for safety reasons, that we have unsatisfactory results regarding the skin, even in those who do not have skin problems before. So I think, in summary, we can say yes, ethinyl estradiol contributes to the effect, to the therapeutic effect by reducing free testosterone, by increasing SHBG. But still, especially in severe cases, the additional effect of a strong anti-androgenic progestin seems to be more important.
Yes, and a third question is asked by Beatrice Neufeld, and it is, how would you treat hyperandrogenism in menopausal women?
Very good question, thank you. I mean, we had before, and I don't know whether this is still available in Germany. In Switzerland, it's no more available. We had this preparation with CPA in a menopausal preparation, which was called Climene, where you had, I think it was estradiol valerate and CPA in a low dose. We don't have this at our disposal anymore. So actually, I'm building up a sort of an anti-androgenic preparation by combining, for example, transdermal estrogen with a low-dose CPA. So to replace this missing drug, which was available. And I think, in fact, we underestimate the frequency of those women, of those perimenopausal and postmenopausal women who really suffer from hyperandrogenic skin symptoms.
Thank you very much. And the last question from, thank you very much. And the last question from Gulab Shana Khan is Dianet contraceptive as well, or do we need a COC in combination?
What was the name of the drug?
Dianet. Dianet, yes.
Yeah, I think if I'm right, Dianet is also a low dose combination with CPA. I think it is or are you talking about, is this like Valette in Germany? Could you tell me what are the components of Dianet?
Yes, I think we should wait for the answer from the person who is asking this question.
It's probably Dienogest, I assume. Yeah.
Yes, we're still not receiving any feedback. So,
well, I assume what the colleague is asking is about Dienogest, which in many countries is Isan. Is that probably? If that is the question, I do believe that it is that it has a contraceptive effect. I use it also, and but this is of course sort of off-label. I think it has been shown that it has a clear anti-ovulatory effect. And Dienogest also, as I've shown in one of the slides, has an anti-androgenic potential.
all right, thank you so much, Professor. And this concludes the presentation and the webinar. Thank you so much for your wonderful presentation and all the attendees for being here today. Just a quick reminder, you will receive a brief survey that pop up when I end the webinar, and we appreciate your response. Thank you, everyone, and have a great rest of the day.
Thank you. Goodbye to everybody. Bye-bye.
Bye-bye.